Good morning, students. Today we will see the menstrual cycle. So it is otherwise called female sexual cycle. So female sexual cycle refers to monthly rhythmic sexual cycle occurring in females during the normal reproductive period. So this rhythmical changes occurs in the ovaries and accessory sex organs like uterus, cervix and vagina. So we can divide this female sexual cycle into ovarian cycle, endometrial cycle and the changes in cervix uteri, changes in vagina and other changes which occur during the sexual cycle, and also the hormonal control of the female sexual cycle. So first one we will see the ovarian cycle. So this ovarian cycle is divided into follicular and luteal phases. Follicular phase lasts for 14 plus or minus 7 days and luteal phase is 14 days. And the definition of the ovarian cycle is that it refers to the rhythmic changes occurring in the ovaries during each female sexual cycle of about 28 days. So ovarian changes occurring during the female sexual life completely depend on the gonadotrophic hormones which are secreted by the anterior pituitary. The first half, that is 14 days of the cycle, are occupied by the development of the follicles. That is why this phase is called as follicular phase. You can see here in the picture. So ovarian cycle, which is lasting 28 days, we can divide into follicular phase, that is first half 14 days and the next half will be the luteal phase. So this 14 days exactly, it will not be same in all the individuals. It will be differing for each individual because the 28-day cycle is will be changing according to the each and every individual. So again here a detailed picture, you can see the primary follicle and then the secondary tertiary follicles having the theca cells and then antrum, and then the ovulation period which is the 14th day from the last, and then the luteal phase, corpus luteum formation and then corpus albicans. The ovarian cycle, follicular phase. During the first week of the follicular phase, a few primordial follicles start developing. But by the end of 1 week, only one follicle continue to develop further while the remaining follicles become smaller and disappear. That is, they undergo atresia. So this follicular phase is also called pre-ovulatory phase. And the follicle that continue to develop finally has a cavity filled with follicular fluid, and on one side is the ovum surrounded by the granulosa cells. The granulosa cells are further surrounded by two layers of theca cells, theca interna and theca externa. On the 14th day of the cycle, the follicle ruptures. The ovum together with the few surrounding granulosa cells is shed into the abdominal cavity. So this is the Graafian follicle or the mature antral follicle. The oocyte is surrounded by a gelatinous ring, zona pellucida, by the granulosa cells of the cumulus ophurus and by the follicular fluid, that is the antrum. Thinning of the outer follicular wall of thecal cells occurs just prior to the ovulation. Rupture of the follicle at ovulation ejects the oocyte cumulus complex. And the remaining follicle forms the corpus hemorrhagicum in the ovary. The process of ovum being discharged from the follicle is called ovulation. So after the pre-ovulatory or follicular phase, the next phase is the ovulation phase. So the developing follicles will be finally at the maturation point, the stigma will be there. At that point there will be rupture occurs, releasing the ovum. The early growth of follicle is due to the action of the FSH secreted by the anterior pituitary. The production of this hormone in childhood is negligible, but it increases just before puberty. It acts on the primordial follicle of the ovary and leads to proliferation and growth of the granulosa cells and theca interna. Under the influence of this hormone during each menstrual cycle, one of the primordial follicle is converted into Graafian follicle. So there are many follicles present in the ovary, but it seems to be related to the ability of follicle to secrete estrogen inside it that is needed for the final maturation. So that follicle will be selected and it will be converted into the Graafian follicle. And this Graafian follicle takes 14 plus or minus 7 days to mature. So this Graafian follicle takes 14 plus or minus days to get matured. The granulosa cells and theca interna produce estradiol. This hormone acts on the genital tract and causes hypertrophy and hyperplasia of the tissues, and it is responsible for the development of secondary sexual characters. So what are the changes seen in this Graafian follicle? So this Graafian follicle itself may come as a short question for you, or the very short question. So the size of the follicle increases markedly to 2 to 5 mm, and it extends throughout the whole thickness of the cortex of ovary, and at one place it encroaches upon the tunica albuginea and bulges out of the surface of ovary into the peritoneal cavity. And in the meanwhile, the antrum also becomes larger and distended with the fluid, and the follicular fluid collects in such a large amount that it surrounds the ovum all around except one point. So except one point, as a result, the ovum covered by a layer of cells called corona radiata remains in contact with the granulosa cells only at a hill-like area called cumulus effurus. Okay, so the theca interna becomes more prominent, and the estrogen secreting cells of the theca interna increase and are called the cells of theca glands. So just prior to ovulation, the primary oocyte of fully matured Graafian follicle completes the first meiotic division and forms the secondary oocyte with haploid nucleus and the first polar body. So in brief, I have explained the changes taking place in the Graafian follicle. And the estrogen increases the number of FSH receptors on the granulosa cells, which in turn leads to release of more estrogen, resulting in positive feedback loop. Further, combined action of FSH and estrogen leads to expression of LH receptors on the granulosa cells and theca cells. Availability of LH receptors leads to progesterone secretion towards the end of the follicular phase. So this is the feedback control of FSH and tonic LH secretion during the follicular phase. You can see here the hypothalamus GnRH secreting cell. So it will cause the stimulation of the gonadotroph cells in the anterior pituitary. So that will cause the stimulation of LH and FSH, which will again stimulate the Graafian follicle to release the estrogen production. So the estrogen carries a positive feedback loop on the Graafian follicular cells so that it releases again more estrogen. So this is the positive feedback loop, and the estrogen is having negative. It selectively inhibits the FSH secretion and also on the FSH secretion from the anterior pituitary. So this is the negative feedback action of estrogen on the FSH secretion from the anterior pituitary. And the inhibin released by the Graafian follicle, it selectively again inhibits the FSH secretion from the anterior pituitary. So this is the inhibin extra hormone which is released from the Graafian follicle. Menstrual cycle or the female sexual cycle, the first one we are seeing the ovarian cycle. In that, the follicular phase lasts from 0 to 14 days. The primordial follicle develops to Graafian stage with atresia of the neighboring follicles. LH-FSH receptors are upregulated in theca and granulosa cells. Estradiol levels increase and cause proliferation of the uterus. FSH and LH levels are suppressed by the negative feedback effect of estradiol on the anterior pituitary. Progesterone levels are low in this phase. And for the ovulation to occur, the most important point or the situation to take place is the LH surge. So a finely programmed positive feedback mechanism leads to a sharp rise in LH secretion about 6 hours before ovulation. The LH surge is essential for ovulation. So in this picture you can see here the graphical representation of the estrogen and progesterone and also FSH and LH. So at the time of ovulation there is a sudden surge of LH, so which is responsible for the ovulation to take place. LH is produced by the basophil cells of the anterior pituitary. It acts on the mature Graafian follicle and leads to shedding of the ovum and conversion of Graafian follicle into corpus luteum. This hormone is produced in small quantities continuously, but a sudden surge takes place in the middle of the cycle, which leads to ovulation. This is due to positive feedback by the estrogens acting on the hypothalamus and anterior pituitary. So the reason for LH surge is itself again positive feedback by the estrogens. So ovulation occurs 14 days before menses. So this is the exact line which you have to remember. Ovulation is fixed. Whatever the length of the cycle the individual is having, it is fixed at the 14th day before menses. That means after completion of that one cycle, the first day, starting from the first day of the cycle, you have to count back 14 days, and that day you can tell actually ovulation has taken place regardless of the cycle length. So thus in a 28-day cycle ovulation occurs on day 14, and in a 35-day cycle ovulation occurs on day 22. So see here the change in the number of the ovulation day depending on the cycle length. If it is a 28-day cycle, definitely it will be on 14th day, and if it is on a 35-day cycle, it will be on day 22. So you have to minus 14 from the cycle length. A burst of estradiol synthesis at the end of follicular phase has a positive feedback effect on secretion of FSH and LH, leading to LH surge. Ovulation occurs as a result of estrogen-induced LH surge. Estrogen levels decrease just after ovulation but rise again during the luteal phase. Cervical mucus increases in quantity, it becomes less viscous and more penetrable by this. So you can see here control of the LH surge at ovulation. So GnRH again releasing or stimulating FSH and LH. So this causes positive feedback on the ovulation. Increased LH surge or burst in LH secretion causes the ovulation to take place. The high level of estrogen is having the selective stimulation, that is positive effect on the LH surge and also on the hypothalamus, and the inhibin secreted from the mature follicle is responsible for the negative feedback on the FSH. The indicators of ovulation are approximately 1 degree centigrade temperature rise is observed after ovulation is associated with progesterone secretion by the corpus luteum. Cervical mucus increases and becomes watery, and spin barkit can be formed associated with estrogen peak prior to the ovulation. So this is a phenomenon where you can see the fern-like appearance. And the Michelmus, that is pain in the middle, may be felt. It is caused by irritated membranes at the ovulation. Spotting is associated with the fall of hormone support from the endometrium at the mid-cycle. So this is the temperature recording where you can see 1 degree centigrade rise is noted at the time of ovulation and after that. And next, coming to the ovarian cycle or the luteal phase. We have completed the follicular and ovulation, and then now going to the post-ovulatory or post-luteal phase. Sudden surge of luteinizing hormone of anterior pituitary takes place in the middle of the cycle. This hormone acts on the mature Graafian follicle on 13th to 14th day of the ovarian cycle and cause rupture of the follicle and shedding of the ovum. Empty Graafian follicle is converted into corpus luteum. Corpus luteum takes 3 to 4 days to mature, that is 17 to 18 days of the cycle, and function for 5 to 6 days, that is 23rd to 24th day. It starts degenerating after 24th day, and degeneration is complete in 4 to 5 days by the end of the cycle. After degeneration, corpus luteum finally acquires a white color because of fibrin deposition. This is called as corpus albicans. So again, during the luteal phase, the feedback control. So LH is responsible here. FSH is not given. See, so only the LH is present, which acts on the corpus luteum to cause high levels of progesterone and estrogen, and these will have negative feedback effect on the anterior pituitary, and the estrogen will have positive feedback effect. So progesterone will have negative feedback effect and estrogen positive feedback. And if fertilization of ovum takes place, the stage of degeneration is delayed delayed and corpus luteum continues to function for 13 to 14 weeks of the pregnancy. This is due to production of human chorionic gonadotrophin by the trophoblast of the fertilized ovum. At this stage, the placenta takes over the function from corpus luteum completely. So corpus luteum begins to develop in the luteal phase and it synthesizes estrogen and progesterone. Vascularity and secretory activity of the endometrium increases to prepare for the receipt of a fertilized egg. Basal body temperature increases because of the effect of progesterone on the hypothalamic thermoregulatory center. If fertilization does not occur, luteum regresses at the end of the luteal phase. As a result, estradiol and progesterone levels decrease abruptly. So this abrupt decreased levels is the cause of the shedding of the endometrium. So that is menses, day 0 to 4. Endometrium is left off because of the abrupt withdrawal of the estradiol and progesterone. So you have to remember these important points of different phases and also you have to draw the diagram. Then it will be completely giving the answer for the question. So if this ovarian cycle is asked, you have to draw the diagram and then write all these few points, important points about the each and every phase. And then we go to the uterine cycle or endometrial cycle or menstrual cycle. So all these are synonyms. So what is this uterine or endometrial cycle? So it refers to cyclical changes occurring in the endometrium during active reproductive period in females leading to recurrent monthly bleeding per vaginum or menstruation. So towards the end of the menstrual cycle, the corpus luteum degenerate to form corpus albicans. The degenerated corpus luteum cannot synthesize much estrogen and progesterone. Withdrawal of these hormones leads to breakdown of uterine wall and bleeding resulting in menstruation. So this is one description and actual definition is the cyclical changes occurring in the endometrium during the active reproductive period in females leading to recurrent monthly bleeding per vaginum. So that is the exact definition. So conventionally the onset of bleeding is considered as beginning of menstrual cycle. So bleeding continues for about 4 days and by the day 5 ovarian follicle is sufficiently developed to secrete considerable quantity of estrogen. The uterine wall not only starts getting repaired but the endometrium thickness also starts increasing. During menstrual cycle, all superficial uterine epithelium is shed. So these are the uterine changes. You can see the menstrual phase where the thickness is very low because all the thickness of the endometrium is shed off, and during the proliferative it starts increasing, and then ovulatory period, and then secretory, which the blood vessels will be getting filled up. The endometrium responds to the ovarian hormones, estrogen and progesterone. The ovarian activity is divided into follicular and luteal phase. The estrogens are produced during these phases, but progesterone is produced only by the corpus luteum during the luteal phase. Endometrium response is accordingly to the ovarian activity, correspondingly to the follicular. So accordingly to the follicular and luteal phases of the ovarian cycle, endometrium response is divided into 2 phases, proliferative and secretory phase. The endometrial cycle corresponds to the ovarian cycle and it lasts for 28 plus or minus 7 days. So the first proliferative phase starts on the first day of menstruation and lasts for about 14 plus or minus 7 days. The following endometrial changes take place under the influence of estrogen from the ovaries. So menstruation lasts for 2 to 8 days and the endometrium is shed during this stage, and the entire endometrium is not shed simultaneously. Only a small area undergoes necrosis and are lost. So there is patchy loss of endometrial area. The shedding of endometrium due to necrosis of superficial and intermediate zone of the endometrium. Withdrawal of hormones causes spasm of blood vessel, which leads to ischemic necrosis of the endometrium. And the blood loss during menstruation is 5 to 80 ml. So you can see in this picture the days of the menstrual cycle. So menstrual phase is first one 1 to 5, and proliferative 5 to 15, 14, 15, and then secretory, and then again menstrual. So this is the one cycle where in the first proliferative phase the estrogen effect is more, and then after that we have both estrogen and progesterone effects. Again, this is the individual picture showing the progesterone and then estrogen levels and then LH FSH levels. So this is also again one more picture showing the endometrial cycle. So this is the very important picture where you can combine all the changes taking place in the female sexual cycle. The first one is gonadotrophic hormone levels, FSH, LH, and then ovarian cycle, and then ovarian hormones, that is estrogen, inhibin, and progesterone, and then uterine cycle. So all these things you can get in one picture like this. And the proliferative phase, menstrual contents are the blood mixed with the shed endometrium, prostaglandins, and fibrinolysin. And blood is of arterial origin and it does not clot. Duration is 3 to 5 days with ranging 1 to 8 days, and the amount is 5 to 80 ml. Reparative stage after menstruation, most of the endometrium is lost and only basal layer and basal part of the gland survive. The repair of endometrium starts during the menstruation by proliferation of basal layer of endometrium and epithelial lining of the glands. The cells of the basal layer proliferate under the influence of estrogen. Following changes takes place during this stage. The cuboidal epithelial cells of the basal layer proliferate and multiply. The endometrium, which had become very thin, 1 to 2 mm due to shedding during the menstruation, increases in thickness. Blood vessels also multiply in new endometrium and supply the blood. The lining of cells of endometrial glands undergo mitosis to form long tubular glands and surface epithelium of the endometrium. The lining of glands changes from cuboidal to columnar epithelium with a basal nucleus. There is no secretory activity in the glands during this phase. At the end of this phase of proliferation, the endometrium is vascular and thick, that is 3 to 4 mm, and tubular glands are straight. The cervical epithelium does not undergo cyclical changes like endometrium. In the proliferative phase, cervical mucus becomes thinner and alkaline, and this facilitates the entry of sperms into the uterine cavity. This phase constitutes, and the next one is secretory phase. So this constitutes the last 14 days of menstrual cycle and its duration is remarkably constant. During this phase, endometrium becomes thick and hypertrophied. Glands undergo changes in shape. They become elongated and coiled. Also, they secrete a thick viscous glycogen-rich fluid. In this phase, stromal cells cytoplasm is increased in volume. Glycogen and lipid accumulates inside the stromal cells, and these can provide nourishment to ovum after fertilization until it establishes an alternative nutritive source. In this phase, cervical secretions become thick, preventing the entry of sperms. At the same time, uterine muscle is inhibited by progesterone, and this minimizes any chance of abortion. In the secretory phase, the coiled spiral arteries supply the stratum functional, the superficial 2/3 of the endometrium, whereas short and straight basilar arteries supply the stratum basal, the deeper 1/3 of the endometrium. So, coiled spiral arteries supply the superficial 2/3 of endometrium, and whereas short and straight basilar arteries supply the basal part. So these changes were brought by combined action of estrogen and progesterone secreted from the corpus luteum, preparing the uterus for implantation of the fertilized ovum. So this is known as luteal phase. So next is the hormonal control of the menstrual cycle. Main aim of the gonadotrophins is to prepare the endometrium each month for a pregnancy. So how this is happening? Hypothalamus releasing GnRH, causing increased synthesis and release of FSH and LH from the anterior pituitary. So you remember here the picture which I have shown you in the previous slides. The hypothalamic control of the anterior pituitary is cyclical. So increased FSH causes increased development of ovarian follicles. Increased estrogen secretion from the theca interna cells, proliferative changes are occurring in the endometrium. And increased FSH leads to increased estrogen to reach a peak at 12 to 13 days called estrogen surge, which is responsible for the pituitary to increase the GnRH, which occurs within 24 hours. That is, a burst of LH secretion or the LH surge takes place. And ovulation occurs about 6 to 9 hours after the LH surge, and this is called ovulating hormone. At the same time, when LH peak occurs, FSH also suddenly rises to peak, that is FSH surge. After ovulation, serum LH and FSH concentration falls to very low values for the rest of the cycle. But as the corpus luteum is formed from the serum progesterone, its concentration increases markedly, and serum estrogen and inhibin also increases, leading to negative inhibition, that is FSH and LH secretion via negative feedback on the hypothalamus. So progesterone acts on the endometrium primed by the estrogen, that is secretory phase of the endometrium development. If pregnancy occurs, corpus luteum persists and continue to secrete estrogen and progesterone. However, its function begins to decrease after 8 weeks of pregnancy. If it fails to secrete progesterone and estrogen, there will be spontaneous abortion. And if no fertilization takes place, corpus luteum regresses and the sharp fall in progesterone and estrogen leads to withdrawal bleeding. So the menstrual bleeding is otherwise called withdrawal bleeding because of the withdrawal of progesterone and estrogen hormones. Once luteolysis of the corpus luteum begins, progesterone and estrogen decrease and secretion of FSH and LH increase, leading to a new cycle. So this is an overview picture where we can see the hormonal control of the female sexual cycle, that is ovarian and uterine cycle. So in the early mid-follicular phase, there is the increase in estrogen levels, which will cause positive stimulation on the granulosa cells and negative on the FSH and GnRH. And in the late follicular and ovulation phase, you can see high estrogen causing stimulation of the GnRH, and also small progesterone causes stimulation of the LH. So the LH surge is present and inhibin causes negative feedback on the FSH. And here the mid-luteal phase, corpus luteum secretes these hormones, which will cause negative on the GnRH and then anterior pituitary, and lastly at the end of the cycle there is decreased level of estrogen and progesterone causing to the withdrawal bleeding. So remember this picture. So if you are getting confused, don't worry, read 2-3 times and then write these pictures and write notes on your own. So this diagram, this graphical representation, follicular phase and endometrial phase, all those things, while reading, draw on a paper, and then after completing 1 or 2 readings, you close the book and try to draw it on your own. Then definitely it is understandable to you and you can easily remember it. Okay, so this is also one more picture showing the entire reproductive or female sexual cycle, where you can see the ovarian changes and the hormonal changes and the menstrual cycle or endometrial changes. And lastly, what happens if the ovary is removed before puberty? So this is the applied aspect, effect of removal of ovary or the gonads in females. So before puberty, if the ovary is removed, the puberty does not set in and the menstrual flow does not appear and secondary sexual characters do not develop. And in adults, there will be atrophy of the whole genital tract and the menstruation ceases permanently. Vasomotor changes are common, like flushing of skin of face, neck and upper chest called hot flushes are seen. And feeling of suffocation and night sweats are present, and the effects on breast are variable and they may increase in size due to local accumulation of fat, or they may shrink due to atrophy of the glandular. Obesity develops due to diffuse deposition of the fat in the individual, and the effect on sexual desire is variable but remains unaffected. The emotional disturbance of varying degree is present, that is from the irritability or depression to insanity. The person may become insane in severe cases. So these are the effects which we see in the effect on removal of ovary in before puberty and after puberty in adults. So that's all for today. So we have seen till now the female sexual cycle having the ovarian and uterine cycle and the hormonal control. So the hormonal control and the menstrual cycle are the very important topics, so which will come definitely as an essay question for your final examination. So don't neglect this topic. So try to read 1 or 2 times and then close your book and write on your own. Take a paper, write the flow chart, the entire picture having all the cycles together. That picture you have to definitely get it without seeing, and then each and every phase you have to explain few points. So if you write the diagram and explain the points neatly, definitely you will score good. Okay, I hope you all understood this topic. So to summarize, we have seen the ovarian cycle, uterine cycle, and the hormonal changes occurring in the endometrial cycle, and finally the effect of removal of ovary before puberty and after puberty in adults. So that's all. Thank you all.